sure if Dr. Consolata can hear us.
Until now?
No, here she is.
How's that?
It's working great. We can hear you.
Okay. I can hear you too.
All right, great.
Wonderful. Just need to understand how to get with my with the slides, how to get on with my slides.
I'll be moving your slides for you.
You will?
Yes, of course, I will do that. You just go ahead.
Okay. Okay. So hello. We are speaking from the other side of the world. How nice to see you. How nice to see all of you. We had a long day of work, all of us, and I'm sure that being the last lecture of your evening must be quite tiring. Therefore, I'll try to be as clear as possible and as easy as possible. Actually, I always like to follow Albert Einstein's quote, who was a very nice Italian man, as you know, and he was saying that if you can explain it in an easy way, it means you didn't understand it well enough. So don't really get me wrong, for who of you already know me and already have heard me lecturing, especially there in Saudi Arabia. I will try really to speak about very complex topics in a simplistic way. So don't get too overwhelmed if some things you think that they seem too easy, but I try to make them easy. I'll take my nice face away from the screen so we can concentrate on the slides. So you can go on if you want to the next slide. As you know, we've been living in the past few months some really extraordinary time. We have lived a pandemic as never we did before in our lives. The lockdown has been for me a great opportunity to become again a full-time student. I've been reading, researching, attending webinars, studying about what was happening, which were the findings that week by week were published, and so on. And really, above that, it's now more than 40 working days that we are back in our clinics almost regularly, with, of course, some a lot of challenging changes in the treatments, in the patient welcoming and approach, in infection prevention protocols, and so on. I then decided for this lecture that I was asked to prepare to share with you, dear colleagues, the major things that I believe need to be very clear in our knowledge to work now safely and efficiently at the same time. Okay, next. Please note my email address. In the time we have is very limited. We are a little late in the schedule. You can go to the next slide, please. You can go on, please. Abdullah, thank you. So please note my email address. So I know how much time we will have at the end of the session for questions, but I will be very helpful, very happy to answer to any of your questions that will arise in the next days. I came up with this idea, the 21st century challenge for dentistry. No, please go back. You're going too fast. Back one.
Slide one, okay.
Back. Okay. The main reason why patients won't show regularly in our office working on prevention is mainly because there's a lack of literacy. What that means? Yes, of course, there is a limited access to routine dental oral care. Next. Next slide, please.
Dr. Consolata, would you be able to share your screen?
How can I do that?
Be better for...
Sorry?
that would be better if you could share your screen.
I know. I would love to. I would love to do that.
Okay, you have access. If you could just go and click on screen share, this bottom here.
And that's what I did.
We will be able to see, yeah, and we will be able to see your screen then.
I have the screen. I can see it, but I just don't have the remote control of going on with my slides.
You just go on, and we'll be able to see what you are doing.
Okay.
You'll be able to see your screen. Okay. So I will end mine, and you will be able to share. Okay.
Okay. I see.
Okay. Now we just need to go and click on screen sharing.
That's what I did. And it chooses how to share your screen. Open the browser or run in an app.
I think you have to download the app to share your screen that way.
Ah, run in app.
Okay, just give me a moment. Okay. Okay, just give me a few seconds. I will try to upload it, and then we will be able to show it on the screen.
Yep.
Okay.
So don't get tired and don't get snoring already. We're almost there. So how is the weather? How is the weather in Saudi Arabia right now?
It's getting hot, actually.
Ah, the summer is almost there. Yeah.
Yeah. So I think I will be sharing my screen until the uploading is complete. Okay.
Yep.
So we don't waste time. Do you see the screen now? Can you see it, Doctor?
No. Yes, I can. Yes. Wonderful. Now I know how to go on. Thank you so much, Abdullah. I'm just a dental hygienist, you know.
You're welcome.
So I was telling you that scarce health literacy is really the main problem that makes our patient unaware of how important it is to have oral health for their total and systemic health also. So, of course, there is a limited access to routine dental and oral care in most of the world countries. But unluckily, the Western population think that oral health is still very linked mainly to aesthetics. Therefore, people will take care of their mouth mainly because they think it's a social issue. And this means that inevitably there is still rate of disease is still going on and is still getting a rise. And dental care and dentistry alone can't face it. So we really need to shift somehow our way of treating and especially making people aware about this health literacy in oral health. The hot topic, as you might know, of course, and we have learned all of this when we were at university, is biofilm. Biofilms are virtually everywhere in a moist surface. And antibiotic resistance is 1,000 to 1,500 times more for bacteria within biofilms than in free-floating planktonic ones. I'd like to point you out the incredible research I've been following of the University of Biofilm Engineering in Montana in the US. It's a wonderful research that is conducted. And as you know, for sure, antibiotic resistance is one of the main challenges in this century. So we really have to be aware and informed about that also. We, as dental hygienists, are, of course, the ones who have to handle these biofilms. Easy enough to reach, we have to think, because really, if you think that biofilms can be everywhere within the body, the oral cavity is quite accessible for health professionals. So since the oral cavity is accessible, simply we need to debride. But before we study the why, the what, and the how we need to debride, let us remember the core concept behind it. Human microbiota varies throughout the body. The most diverse reside within the guts and in the oral cavity. When the microbiota and the human microbiome live in harmony with each other, this is termed symbiosis. You might remember that, and I've been reading about this lately in our literature. Well, if there is any disruption, well, this is called dysbiosis. There is either for external or internal factors, there is an imbalance between this harmony. Health is the balance between pro-inflammatory and anti-inflammatory processes. Here is where the dental hygienist is called to contribute with his or her knowledge to maintain or to recover to health. So we have a huge responsibility and a lot of things to do, of course. If the oral ecosystem is disrupted, if something is going wrong, and the body is unable to regulate the inflammatory response efficiently, well, what happens? Then it will allow disease-promoting microbiome to populate the soft as well as the hard tissues. So something is going wrong there. Dysbiosis in the oral cavity can occur due to many factors such as poor oral hygiene, smoking, stress, saliva flow or composition changes, alteration in diet, medication, and many other factors that you all know. They all belong to the risk factors assessment also. We try to limit the damages of this dysbiosis in the oral cavity by educating and treating our patient. But if we cannot achieve a good level of awareness and control, this will inevitably lead to systemic breakdown. When there is active periodontal disease, the clinician knows two things for sure. One is that the patient oral microbiome is dysbiotic, and that's for sure. And the second one is that oral biofilms are present in quantities and qualities that have caused this dysbiosis. So we have to face a dysbiotic microbiome and oral biofilms. And how do we do that? The best clinical service that a dental provider can serve to their patients is effective biofilm removal, of course. The return to symbiotic balance and immune inflammatory control will result in improved oral and consequently systemic health. This is the reason why valuable groups are looking very much into prebiotic, postbiotic, probiotic approaches as an adjunct to dental treatment. There is a lot of pressure on us, on dental practitioners, to handle the patient with oral and systemic dysbiosis. The oral microbiome is a crucial part in the etiology of caries and periodontal diseases, of course. However, in the light of what has happened in the past few months in this pandemic, we need to update our consideration. And I will point you out the next few slides, some tips for you and for us to follow in these days. As you see in the little red circle, there is a coronavirus. And this is just to remind you some changes or some consideration we need to do.
Dr. Consolata?
Yes?
Can you hear me?
Yes?
I think you're presenting from your computer, but the attendees are watching mine. So if you could take a look at the screen, because I have lost track.
Wow.
I need to get to the slide you're talking about.
Okay. We are having problem with that. So how can we number them? I'm at number 21. So if you want, I can give you the number of the slide as soon as I change it. How does that sound?
You're sharing yours now. Okay, perfect. Now just keep it this way. Keep it this way.
Okay.
Keep it this way, please.
So can you see the little red circle, the
now.
coronavirus in? Okay, that's what I was talking about, actually. That's a little virus, and when you see this little icon next to an argument or a consideration, that really, it relates to the COVID-19 problem and pandemic. Okay? Wonderful.
Okay.
So, that's wonderful. So we need to manage the oral biofilms by debridement, and this is that fine? Okay. So let's briefly review why we need to debride. Of course, we all are dental hygienists, dental professional, and we know already why, but just reviewing it, it just focuses and make you remember, and sometimes it just helps to you to talk about to your patient and explaining simply why all this procedure has to be done in the proper way. Okay. So why? Of course, there is a lot of reasons why, one of which I would say is the main one that usually is the most dramatic and really hits the patient, is that if they have active periodontal disease, each time they chew on food, which might be 2 or 3 times a day, they experience transient bacteremia, which is a huge can be a huge problem for most of them. So that would be a good enough reason. But also, if you look at epidemiology, you will see that caries is another huge problem, which is the 4th chronic disease worldwide. Half of the population apparently suffers of a period disease in some degree. And the prevalence is similar in urban as well as rural areas. And there is no real distinction between socioeconomic status. And it can hit all ages, although the older ages are the one that has more individualized dental and periodontal problems. So there are quite a few reasons why we have to handle and debride and handle these biofilms. Another good examples that can impress our patient and our advocacy, which means to say the people that we know in our families and friends and people we encounter outside of the office, is that if you have a group of 10 people, of 10 adults, most and probably 6 of them will be healthy or will have gingivitis, but 3 will have moderate periodontitis and 1 will have severe periodontitis. And you think of that in a room, it could be most of us that has some sort or some degree of periodontal disease. So this makes you think and really confirms the need that debridement and biofilm control is essential for our overall health. The trends of the dental clinician we look at the future should really shift towards major responsibilities on the patient overall life. We will then need to maintain health, function, and aesthetics, of course, as well as we will have to prevent the recurrence of disease. And of course, we will intercept dysbiosis and inflammatory processes, alterations, of course. And finally, we will always have to reduce the risk of treatment failure. So there is quite a lot. We as dental professional, hygiene professional, health maintenance professional, we need to do towards the population we visit in our offices as well as we visit in our life as an advocate, as I was telling you earlier. So it is indispensable for any positive prognosis of any dental treatment to have oral health maintenance. All right, so we really need to make clear to all our colleagues and professionals we're working with in the team that if there is no oral health maintained and controlled, no big, huge, wonderful dental treatment will be achieved in the long run and will be maintained. So very important, and I think that you all are agreeing with me. So as you see, the oral health is at the base of any quality intervention. And you know that biofilms, as I was telling earlier, just adhere to any moist surface that can be very comfortable and will have the growth and the maturation of it. That can be also hard tissues like natural teeth or restoration surfaces, as well as soft tissues. Just think about the tongue surface, how full it is of biofilms. So we really need to understand that removing calculus is actually removing biofilms, because biofilms just will stick anywhere it's rough, it harbors, and it will remains easier, and our tissues will not remove them in a natural way. So removing calculus, of course, takes significantly longer time than removing biofilm. And even if calculus is not the etiologic factor in the pathogenesis of the perio disease, it strongly contributes to the accumulation of and maturation of those pathogenic biofilms. Therefore, active and effective removal of calculus is crucial. Calculus creates a roughened surface to which biofilms adhere, and its non-mineralized portion harbors microbiota and other debris constantly. So removing calculus promotes symbiotic relationship between oral tissues and oral environment. Again, we're talking about symbiosis. It's a very fashionable word we're actually facing with each time we look and read about dentistry lately. The fastest and the most effective way to remove biofilm is still mechanical disruption. The literature really have been talking and researching and seeing which is the fastest way, and mechanical removal is really the fastest and the easiest and a more drastic way to do it. And you can read a lot of wonderful works that will really confirm these ideas. There is no real other way of weakening, preventing, or disrupting or killing better than the mechanical removal. So calculus is our main objective, actually, because when we speak about calculus, we actually automatically speak about biofilm. But let us focus on the differences of managing supra and subgingival biofilm. Based on the amount and the location of the supragingival biofilm, the removal will be either at home or on the dental chair by different means. We already know them, and they've been working and affecting in the time, of course. But if in the chair there is a patient, and interdentally, as the colleague before me was telling, there are many means, they're all effective, and that it's about all your physiotherapy that you want to share with your patient. And if you want to remove the supragingival calculus, that means are always a traditional by scaling, okay? And again, if you do scale, you automatically deplaque and debride also, because everything that sticks on the calculus will be removed, either manual means or mechanical means, and we will see the differences, of course. But if in the chair there is a patient with perio disease, then the story will change, because the location of the biofilms will be actually below the gingival margin, even in deeper pocket. And what is inducing the dysbiosis and the buildup of this biofilm is then clear to you. That is well different from what is causing the reactions. Yes, because this next slide really shows you the two major group of problems we actually have to deal with. Yes, it's always the same coin, but the two sides, okay? What is causing is the bacteria, and what is the reaction is the inflammation. Actually, I would like to share with you in my latest experience after the COVID lockdown, what I've been seeing in my patient, that this inflammation reaction has actually been exacerbated or really came up and are augmented, especially in the smoking, who were smoker actually were more and smoking more than before. Medication and drugs, especially for the stress reduction, are actually more given and more taken by the patient. And nutritional changes, people change the way they feed themselves. I see, especially here in Italy, we all became wonderful cooks during the lockdown, and we all put on weight. Some patients started eating better because they were out all the time, especially for the lunch break, and some others started eating worse. So there are some consideration to make in this pandemic phase 2 about all the risk assessment. Subgingival biofilm management, you have in the subgingival areas, of course, you have adjuncts that are technologies that can be added to the control and the debridement of the biofilms, like air polishing, laser, ozone, irrigation with gels or with solution that are antimicrobial or antibiotics. All work well, but we need to know that in this area, in this time of phase 2, some of these will have a limited prescription because of the pollution of the air for the COVID problem. Okay, now we really see a little bit very fast what and how you do all this road to go and do the treatment. Before any treatment, of course, you need to perform a wonderful assessment, and that means gathering data that will be essential for you to make a diagnosis and eventually to plan your treatment in the future and the next future in a timeline, in a short term, mid-term, and long term, which is something that you always want to share with your patient and have their acceptance. And when we talk about patient-centered therapy, which is something that actually is very stressed out by the evidence-based dentistry, is not such a new approach to patient. If you think it was promoted by Hippocrates 2,500 years ago. So yes, we need to make our tailor-made treatments. And everything depends on the person we have in our chair, and depends also from the clinician that we are, because it's the connection of these two people that will make the best out of the treatment. It's really the connection of the case and the clinician itself. So always remember, it's something very different from one person to another. And to briefly review what are the data gathering of the assessment, never forget any of this. Never give for granted that all of these points have to be done more or less. It has to be very top quality. Medical history review, the soft tissue intraoral and extraoral exams, all the things we have learned in university, of course. Dental assessment, not only for caries on other lesions, but also for hypersensitivity. And we have to know the feedback of the patient, the integrity of all the restorations. Essential is also the saliva assessment, the quantity and the quality. This will really determine a lot of the output of our treatments. Orthodontics and malocclusion assessment, periodontal, radiologic, and of course, last but not least, I would say, it's important to know what the patient's signs and symptoms are, and what their desires are, and what they are there for, and what are the top requests are, because it's a mix of all of these that will make the success of our treatment and our relationship with them. Just to review, which are the tools you need for your data gathering. Yes, you will need explorers, you will need probes. You know all of this very well. You have a lot of tools and charting techniques, data charts to share with the patient, to keep in records for your office and for other colleagues that will have to share the information you gathered. And the explorers are really the only most sensitive instruments that will help you to gather all this data. Probing in your periodontal assessment is of course essential. I'm sure that for you who are more experienced, you have favorite probes compared to other, and I really enhance you to have your perfect one that you know how to read quick enough to feel comfortable, to know where to insert it and how to insert it, and to have the correct technique. So there is not one probe better than the others, but just please have your favorite and try to stick on that, because probing gives you so much information also for the results and the checking of your treatment and the re-establishment and the re-evaluation. So it's I would say the number one tool we like to have and we like to know. One option is to have also those double-ended probes that have the plastic end for those areas you do want to be very delicate on, that you want to be extra sure you won't scratch. And that doesn't mean only titanium abutments, but also those other surfaces that can be tender and could be at risk by scratching. So never feel too aware and too safe on the safe side. And biotype probes also can be useful in your periodontal assessment. You might know them already. They will actually give you and evaluate the phenotype more correctly of your gingiva, because you know that some areas that you want to evaluate before any kind of treatment, is better to know which is and what is the kind of gingiva you're dealing with, whether it's thin, medium, or thick. And that will also help you in choosing which are the instruments that you will have to use in those areas to predict the contraction and eventually the retraction of the gingiva itself. Or, for example, before the insertion of an implant to some surgeon, they might need to know the phenotype of that area, whether to choose one size compared to another of the abutment and to insert. Or, for example, before an ortho treatment, knowing the phenotype of that area will predict eventual retraction and eventual recession of the gingival margin. So it's something that really might help very much in predicting the result of some dental treatments. But beware that you might find some areas with a naturally thin or medium or thick phenotype, but throughout the time, maybe after abrasion or maybe after surgery, it might changes in quality. So it doesn't mean these probes might be used throughout one patient's life just to check that might change throughout their dental life, let's say that way. Of course, if you have a severe periodontal patient, you might need extra tools to make perfect assessment. And that means explorers which have extended terminal shank, neighbor probes for your furcations, like this Explorer 1112, you have after 5 rays, or for example, the Tufts number 17 might be the best option for those very, very narrow and deep pockets to be explored, because in this little scheme that I've done, I don't know if you can see, some pockets could be too narrow for the insertion of the 1112 Explorer, and therefore you will need something that will fit a little better, especially in the lower anterior areas where the roots are very thin and very narrow. So you will have to pick the ones that are actually perfect for your data gathering. Never underestimate your assessment of the risk. IDRA, PRA, karyogram, microbiologic tests, and so on are all very useful to assess the risk, especially in this pandemic period, really, when many factors that could be determining higher risk rate are truly changing, as I was mentioning you earlier. Okay, now that we have all our data and we did it in the perfect way, we'll see how we need to treat these debridement techniques, okay? Let's now see how to achieve good treatment, which instruments can perform effectively this debridement in this phase 2 pandemics. Okay, power-driven or manual? This is a big dilemma that has been going on in literature in the past 30 years, I would say. And don't think, manual is the old way. Power scalar were introduced in dentistry in 1945. So I would say that both manual and mechanical are evolving greatly. So what is the question? What is better? I'm sure you made and you have your own answer yourself, because by being experienced and going on in your profession, you will have one or the other one that you prefer. And again, depending on which is the case and how is the patient, how is you as a clinician, in which time of the day you are working, whether you are strong and fresh in the morning or tired in the evening. And all of these can, of course, be reinforced and then helped out for the debridement in combination with other adjuncts that you might all know, you might have tried. If you have a chance, please do, because they all are wonderful in some way, which can be in a pharmaceutical formula, it can be chemical, it can be thermal, it can be probiotical, it can be antibiotical, and so on. So there are a lot of things to achieve the gold standard that you can actually choose in between. But if you step a little bit backward and try to see and try to find the answer, what is really better, power-driven or manual? Well, you can find either of them. There are really very honorable studies that will tell you what they have been seeing. But actually, what we can see is in vitro or in vivo, what is the result on some surfaces, some hard tissue surface, on your enamel, on your cement, on the surfaces of some restorations. No problem. I mean, you will see, and what actually you will be aware of is that the clinician's expertise will make the whole difference. It's really who will use either one or the combination of the two that will make the difference. Now, Abdullah, can you see the slides or not anymore? Because on my screen, oh, yes, now I see it again. So the clinician expertise is really what will make the difference. It's like if you were a tennis player, if you were a fairly good tennis player, if you have a so-so racket, you will be able to use and make good shots anyway. If you had a wonderful racket, yes, you would make better shots. But again, it's really as much as the technique and your performance that will make the big difference. So be confident that what you have in your hands is really what will make the difference, you as a clinician. But what I actually came up at the end of my consideration is that both techniques are equally inefficient. What means? It means that it's impossible to totally remove the biofilm and totally remove the calculus. Really, and what is the objective for you is to recover and get clinical healing. So be humble enough to know that you will never be able to remove everything perfectly, but you will do it good enough to get healing and clinical healing again. So the most significant bias is the clinician. Try to be the best clinician you ever for any patient at all time, which is the hardest time. I just made a short list of my consideration of the major differences between power-driven and hand instrumentation. And of course, the dramatic aerosol production of power-driven is what worries me the most. That has always been worrying, but more than ever in this phase 2 pandemic. So it's not that the ultrasonic or piezo are more efficient or are faster. The patient tolerance, if you have the proper power, is, I would say, that the same or even worse. It's not that easy and that nice to have power-driven instruments in the pocket. It's just, I would say, it's very individual again. On the other hand, if you are using bladed hand instruments, you are handling sharps, so it's a hazardous maneuver to have. Although the infection control, of course, is better. There is no zero risk, but there are less aerosol production while you do manual scaling and replaning. The clinician training is pretty long and arduous, but and it's fatiguing for the clinician, and you need to sharpen these instruments. So there's pros and cons for each of the techniques you might want to choose or do in combination. But Again, I'm stressing out this phase of phase 2 of the pandemics, and what our association, especially here in Italy, have been recommending is really to avoid using any aerosol producing device for the hygiene department. That means power-driven air polishing, and the same for air-water syringe. Okay, and actually, I know, by the way, that in some countries in Europe, it has been prohibited to use these devices. It's not just a recommendation; it's really a regulatory law. So there are some clinicians, some colleagues in some countries that have no choice. They have to go by hand 100%. And who is not really keen on that has to go back in their school memories and review the hand scaling and replaning and debridement in total. So let me open a little parenthesis on the COVID and the SARS coronavirus, and I will close it in very fastly, because this is not the main purpose of the lecture. But I want you to point out some little tips I've been finding in these days I've been working, that might be useful for you too. And really, I just want to mention you a quote of Dr. Peter Medawar, who was a Nobel Prize winner of biology, that defined a virus like an envelope with a very bad news in it. And that's actually what we are living, because we know what coronaviruses look like. We know much more than what we were 6 months ago, us as dental hygienists, of course. But beside all the matter that belongs to this terrible disease, from our point of view, what we are concerned of is the size of this virus and its virulence, of course, because the size is what really makes the whole handling of the infection control in our clinics to be so arduous. So if you look at the size of different viruses, the COVID-19 virus is really very, very tiny. And that's why, and if you think about it, it's so tiny. If you compare one of these coronavirus to a coin, it can stay and live in an air droplet like a coin in a 25 meters boat. So can you imagine how many viruses can stay in a droplet? And can you imagine how many droplets we can breathe or we can catch in our nose or our eyes? So that's what really fears and makes us work so dramatically. Anyway, I don't know if you have read this article of the New York Times in March 15. It was actually looking and considering the workers who face the greatest coronavirus risk, and you can see that the dentist and of course then the dental team was the most exposed. And this one also is a wonderful study they've been doing on the front line, and they were considering both occupational healthcare related in green and the non-healthcare in blue. And can you see the dental assistant and the dentist on the far right? And again, even more, the dental hygienists were found to be the greatest risk occupational jobs, because the contact with others was very high, the physical proximity and the exposure to disease were the most dramatic and most important. So we are there. We are those in the front line. We are not the heroes of the doctors in the hospitals, but we are out of the hospital the most exposed. And this must be very aware. Again, I like the Libra as the figure that sees the equilibrium. Well, working safely really is a perfect balancing between the clinician protection and the control of the infectious agent. And that means, yes, we have to protect ourselves, but we have also to control where the source of the infectious agent comes from, and if we can handle that in a better way. So the size, as I was telling you, the size of the coronavirus is so tiny that we have to reconsider the filtration properties of what is protecting us in our airways. So masks, you know better. It's not that the surgical masks are not good enough. Also, if we see them everywhere on people walking in the street, surgical masks are still filtering pretty much, and they're still very efficient. But it depends if you are working in an area where these aerosols are probably potentially in a high concentration or not. So it's not that one is one kind of surgical mask that is not to be used anymore, is not efficient anymore. So this is how we look in our clinics, and we try to protect ourselves the most without getting too tired, although it is complicated. It takes more time to get done and to take all these things away in the proper way. We try to, as you see, to work with open windows, which I think that in the Middle East is something quite impossible due to the heat outside, and also mostly all the clinical structures I've been visiting in the past years, I've never seen some windows that could be open actually. So this is something we are lucky enough to have, and we are not having a heat problem yet, but the summer is getting close. So you see shields, you see double mask for filtering our breath from the patient and to the patient. Some other things came up to our attention, and we are actually trying, is there are some screen and mask that actually filters the air, and that could be a good option. Or other things that actually take care about the aerosols source, which is the mouth of the patient, of course, with this inspirator or vacuum or screens between the clinician and the patient. And then actually I've seen in the lecture before this one in Portugal another option of how to work. But again, to be very down to earth, we still are working without any assistance, with no help. We need to work and make it possible for the clinician to self-control and self-doing everything with the patient. So we have to find out what will be the best. So just to resume, which are the major changes we have been doing and trying to do, is that the patient, we consider them anyway potentially contagious also for the coronavirus, because although triages are made, they're not 100% sure, and asymptomatic period can go up to 70 days. So we can actually see anybody sitting in our chairs that is in that phase of asymptomatic portion. The best place for the virus to die is in a dry and heated air, okay? Because it evaporates the droplets, and the heat is also the best place where our bodies are more comfortable, they are less stressed. So ideally, this is the place where we should live, in the open air, in a dry and heated place. But this, of course, is not possible. So try and dilute the pollution in your area as much as possible without, of course, spreading it out in the clinics. So this is the list of things that came up in my mind to share with you. When possible, work with open windows and closed door of the room, of course. We don't make our patients spit anymore in the little sinks. It's only expectoration with the saliva ejectors. We added a rinse of preoperatory rinse beside the chlorhexidine. We ask the patient to rinse with a hydrogen peroxide for 1 minute, diluted. We have both masks, wearing one over the other. We use disposable waterproof gowns. We don't air polish. We don't use power-driven scalers. We dry with gauze without using the air-water syringe. The patient will sanitize their hands before and after getting into the office, and they will wear the mask just until the minute before we start treating. So also in the meantime, while they sit in the chair and they renew their medical history and they talk to us about what happened and what is going on and so on, they will wear their mask. And there is, of course, a sanitization reinforcement between patients. We try to aerate the room for 15 minutes. And beside the usual TBC hospital level disinfectant, we use either alcoholic or a chlorine solution to do a second disinfection of all the areas and the surfaces we've been working on. We actually aim on minimally invasive intervention. We use a little more disclosing solution to go and get the biofilms exactly where they are, and we don't just do extra work because we want to keep the patient as little as possible staying in the office. And we stress out the tongue brushing. Because yes, what we have been seeing and research is really aimed on is what is the biggest harbor in the mouth before the SARS-CoV coronavirus migrates either in the guts or in the respiratory system. It can stay for days along on the tongue surface as well as in the salivary gland, because the tongue is very rich of these AC2 receptors, which are the receptors, these proteins on which the virus stick and hooks to before it replicates and become in a quantity interesting enough to migrate in the lower vials. I suggest you these readings. The European Federation of Periodontology has a lot about the coronavirus, a lot of iconography of images for the patients and for the offices. If you want to download, those are very, very clear. And it just 1 week ago, this booklet came out. It's unloadable for free at this site, and it really gives you, it's all in English, and it really gives you good ideas, very clear and simple, of how to handle the dental practice with this pandemic problem that is we are living right now, everybody. Okay. And what our Dental Hygienists Association actually, as I was mentioning earlier, defined yellow light for non-aerosol generating procedures, which is manual instrumentation and examination, and red light for aerosol generating, which is ultrasonic and air polishing. And we try to avoid those, of course. It's highly recommended. And I would adjunct that also in the complementary hard-to-reach site, it's better to use lasers or manual irrigation with a solution that can be antimicrobial or antibiotic, better than other ways that could be aerosolizing the virus. So there are means that you can actually try and dispense and that can substitute the regular golden standard we were used to until a few months ago. So power scaler can be substituted in the supragingival with very powerful scalers that you might, I'm sure you all know and you will all prefer, with their pointed point. Of course, they have to be very sharp, in a wonderful shape to be at their best in their performance, and you won't get that tired if you have sharp instrument and sharp scalers. The supragingival calculus will come really easily away without getting too fatigued. So go back to your school notes and really reinforce your sharpening. Actually, since we have a lot of dead time between one patient and another because we need to wait for the sanitization, maybe the sharpening could be a good way of passing that time and having wonderful shape instruments. Or you may choose between delicate scaler. I like to call them this way because they might just want to really remove just supragingival biofilms or very tender, soft calculus. Or if you want to remove some spots, some stains, instead of your power and in your rubber cup and paste, the Naviscaler one, which has a beaver tail shape, could be a very good option, a manual option to remove those stains. And that's something that works out for me in these days. And for the regular maintenance, for those patients that come regularly and they have really few deposit built up, I will use the delicate curette. Also, they can go a little bit below the gingival margin. Maybe those patients that had perio disease in the past, but now they can handle it and control it. So the Biogen curette could be a good option for those really recall patients without having heavy duty and hard work for them to be used. Okay, remember also that the choice of the metal or the quality of the glaze you're working on is also determined by the surfaces you're going to treat. Of course, if you're treating natural teeth, you're treating enamel or eventually some cement, well, the stainless steel is perfect. If you're working, of course, on titanium and gold, those wouldn't be the good choice because it's for sure something that will scratch them and will ruin them in the long run. And other restoration materials like zirconia, composite, or resins also can be somehow disturbed or touched and ruined with stainless steel. Therefore, you might want to choose something in titanium that is always gentler on the restoration of the very modern restoration material. And again, the titanium scalers and curettes are sharpenable, and they are very useful as well. They're not as powerful as stainless steel, but that depends, of course, you don't have to deal with these kind of instruments with heavy deposit that will make for it. Universal curettes are very good, and they are very easy to use everywhere in the mouth. And again, there is a lot of choice about that. And when we are talking about minimally invasive curettes, you will probably think about the evoluted Gracies, afterfis, minifis of microminis. Those are really the choice instruments for those of you who love using maybe the perio tips of the power scalers that are nice and thin. And if you are not allowed to use that anymore in this period, well, you will have the option of using microminis or vision curvettes, who really will substitute in a great way, since they are very tiny, very small, and they will reach deep, narrow pockets easily, as well as microminis, of course. So they are called the minimally invasive tools or instruments. I don't know if you know this kind of, I would say they are quite a new group of scalers. They are subgingivally minimally invasive scalers. They are very, very thin, but they have the features of scalers. So they have a very pointed point, but they're nice, thin, and long, and they are really something that you could make very similar to the piezo PS insert, which is something we all know and we all love very much. If you have to go and reach hard places like our furcations that we don't like to deal with, well, you can find some hose, plus irrigation could be the option, or files like the Diamond Tech, which are wonderfully small and tiny. I would compare them to periodontal probes. They have this point which is all covered by diamond powder, so it's just like a nail file, I would say. You go with any direction and you can really reach small, tiny little places, just like where the probes can reach. No other instruments will get that. And that will give you the really final one. And in the Diamond Tech, you also have one model that is just the same shape of a neighbor's probe, and that will work very well in the furcations. And I would say there's nothing else that really could reach. Last but not least group of instruments that you might be needing of in this period are the files, which are multi-bladed instruments that have been in the dental field for many, many years, especially in the oral surgery. And now they did a whole set, which are called the Hirschfeld files. And they are very tiny. They're smaller than the oral surgeon ones, and they are good for deep, narrow pockets, of course, furcation, developmental grooves. Also, when you have to handle your burnished calculus, because that's really the main reason, the only instrument that in re-instrumentation appointments that you will be using. So you can see that a whole set of different instruments you might be needing of for periodontally active and deep pockets, as well as you might need very few for supragingival debridement itself. But now I'm just concluding, making you 3 wishes, and hoping that you really agree with me with this. You need to keep our ethics at the highest level. Although we are facing and living a very difficult period of our profession and our lives, but it's a challenge, it's an opportunity. You have to really see it as something positive. If you feel you're working and you're fearing to get somehow in danger, don't work. You really have to be safe and very tranquil, and of course you have to tranquilize your patients, otherwise everything will be much worse. Perform always the gold standards approach in the safest ways, and there is the option. There are the option, you might just need to know them and choose them and try them. And for the last thing, maintain correctly your instruments. The misuse and poor techniques can be detected just a year later. Maybe it's too late when you will actually recognize that you are doing mistakes. So go little step by little step, and you will achieve very well as you did until Christmas time. Okay, thank you so much, and hope you have a good night.
Thank you so much. Thank you, Dr. Pejrone, for the great, full of information presentation. On behalf of the Saudi Dental Hygiene Society, I would like to present to you this certificate of appreciation for your participation in today's session. Dear attendees, there are no questions from the attendees so far. So please, our dear attendees, please take a moment to take the speaker assessment survey, and please note your names will not be revealed to the speakers, to our presenters today. Dr. Pejrone was the last speaker for today's session. So thank you, Dr. Pejrone. By the end of today's session, on behalf of the Saudi Dental Hygiene Society, I would like to thank our speakers for their insightful presentations. And I also would like to thank you, our dear attendees, for your contribution throughout the session. Just a quick reminder, please note that the attendance certificates will be emailed to those who successfully registered and attended the conference, inshallah, afterward, after the conference. And also, I would like to remind you that we will, tomorrow's session will start at 7 p.m. Arabian Standard Time. By the end of today's session, we wish you a lovely evening, and we are looking forward to seeing you tomorrow. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you so much to everybody. It was really an honor to participate to your first Saudi Dental Hygiene Society International online conference. You finally made it, inshallah, and we are so proud of you that you are now a society recognized worldwide, and please keep on going in the right direction. Thank you.
Of course, thank you so much for your kind words, and thank you everybody, and we will see you inshallah tomorrow at 7 p.m. Thank you so much.
Bye-bye.
Bye-bye.